Hi everybody, welcome to this video. I reformatted my notes a little bit differently this time for endocrinology. So what you can see here is that I tried color coding information. Like if it's in red, then that means like that's urgently information that I didn't know properly. So then I need to like study that. And then I used other colors as well, but I usually just stuck to like bold and black. So that was just mostly to keep my eyes like engaged while I was studying to make it like look nicer. So these are my notes for endocrinology. These are all the high yield notes that I ascertained. This isn't like all inclusive. I would say this is probably like 60 to 75% inclusive of the information you have to know for USMLE Step 2 CK. So I hope that this helps. It's going to be a little bit of a longer video because I want to get through everything. And so let's get right into it. So, clinical features of primary hyperaldosteronism. So, hyperaldosteronism, the clinical presentation is going to be hypertension, metabolic alkalosis, hypokalemia, mild hypernatremia, no significant peripheral edema due to aldosterone escape. The diagnosis is made with elevated plasma aldosterone levels, low plasma renin, and that's high yield to note. Remember, low plasma renin. And then this is also high yield to note that the PAC to PRC ratio is greater than 120. So there's elevated plasma aldosteronism and low plasma renin, and that helps differentiate secondary from primary because in secondary hyperaldosteronism, the renin is also high. So adrenal suppression testing confirms after oral saline load confirms the diagnosis. Abdominal imaging and adrenal venous sampling can distinguish between a unilateral adrenal adenoma and bilateral adrenal hyperplasia. So if it's unilateral adrenal adenoma, then the venous sampling will show like 4 times the amount of the hormone that you're looking for versus bilateral adrenal hyperplasia where it will be the same in both adrenal glands. The treatment is going to be surgery for unilateral adrenal adenoma, and that's preferred. But for poor surgical candidates, you can use aldosterone antagonists such as spironolactone and eplerenone. And then for bilateral adrenal hyperplasia, the main treatment option is going to be aldosterone antagonists. So keep that in mind. You would think that actually it makes sense because you can't do surgery if they're both enlarged because you can't like take away both adrenal glands. So that's how you can remember that you give aldosterone antagonists for bilateral adrenal hyperplasia. The next one is going to be clinical features of hypopituitarism. So clinical presentation for hypopituitarism is going to be ACTH deficiency, hypothyroidism or central hypothyroidism, and gonadotropin levels are going to be low as well. So ACTH deficiency is going to be secondary adrenal insufficiency. So you're not going to have signs of like hyper pigmentation that you see with ACTH with primary adrenal insufficiency because ACTH is low. So these patients will present with postural hypotension, tachycardia, fatigue, weight loss, hypoglycemia, and eosinophilia, a high yield eosinophilia. Hypothyroidism central, so fatigue, cold intolerance, constipation, dry skin, bradycardia, slow deep tendon reflexes, gonadotropins. Women will present with amenorrhea and infertility, and men will present with infertility and loss of libido. The next one is milk alkali syndrome, and it's caused by large amounts of calcium in conjunction with absorbable alkali, so supplement for osteoporosis or antacid. Metabolic abnormalities, and this is high yield, hypercalcemia, metabolic alkalosis, and kidney disease. What are the LH and testosterone levels in men with prolactinoma? That would be hypogonadotropic hypogonadism, secondary hypogonadism. So there's increased prolactin, which leads to decreased GnRH, which leads to decreased LH, which leads to decreased testosterone. What is the most appropriate definitive treatment for a patient with severe ophthalmopathy secondary to Graves' disease? That would be thyroidectomy. Radioactive iodine is contraindicated in patients with severe ophthalmopathy. Tetrutuzumab and tocilizumab biologics may also be used. Hypernatremia with a urine osmolality of less than 300 suggests diabetes insipidus. Tight blood glucose control in patients with diabetes is most likely to decrease the risk of microvascular complications such as retinopathy and neuropathy. The macro complications such as MI and stroke, the effect of tight blood glucose control is uncertain. When you are correcting potassium levels, or when you're correcting, not potassium, but glucose levels for DKA, once the K drops below 5.2, you need to add potassium to the IV fluids. Aldosterone levels are normal in patients with central adrenal insufficiency because aldosterone is regulated by RAAS system, and thus it's not lost in central AI. Hyponatremia can occur in primary and secondary, though in secondary it is more mild. Primary adrenal insufficiency, super high yield. Patients are going to present with hyperpigmentation because there's elevated ACTH and hyperkalemia as well. Hyponatremia and hypotension. And then secondary adrenal insufficiency, they'll present with less severe symptoms. There's no hyperpigmentation, there's no hyperkalemia, and there's possible hyponatremia. Most common cause of primary is going to be autoimmune. Most common cause of central is going to be chronic glucocorticoid use. How do the following laboratory values change in secondary hyperparathyroidism? And PTH is decreased, PTH increased, PTH is increased, calcium is decreased, phosphorus is increased. If it is due to vitamin D deficiency, then there will be decreased phosphate because the kidneys are still working. A prolactinoma level of 200 or greater than 200 is virtually diagnostic for prolactinoma. What hormone is directly inhibited by prolactin? That would be GnRH. So GnRH is directly inhibited. This is also very high yield. Urine osm of less than 100 suggests primary polydipsia or malnutrition, such as beer-potomania. So what happens is that the kidney's reabsorptive capacity is at its max. So sometimes the tea and toast diet, which is used for weight loss, or the beer-potomania, all calories from beer, what happens is that there's decreased salt intake, or water excretion is limited by the amount of salt in the diet. So you're not getting rid of the water. So I would just memorize this. So urine osm less than 100. Think of primary polydipsia. Diabetic gastroparesis may be managed with small, frequent meals and prokinetic agents such as metoclopramide, erythromycin, and cisapride. What is the initial management for a patient with heat intolerance, sweating, and palpitations with a low TSH and a high free T3 and T4? That would be a beta blocker. So you want to give a beta blocker plus anti-thyroid drugs such as methimazole. In patients with significant symptoms and thyroid hormone levels greater than 2 to 3 times normal, pre-treatment with anti-thyroid hormones is recommended prior to radioiodine therapy. But remember, the one case where you don't really want to give radioiodine therapy is when they have ophthalmopathy. So just remember that. Those are eyes, by the way. These are eyes. So when they have ophthalmopathy, you don't want to give radioactive iodine because that can make it worse. Polyuria in non-hospitalized patient can be due to primary polydipsia or diabetes insipidus. So increased urination can be either due to primary polydipsia or diabetes insipidus. Key here is that primary polydipsia patients will have hyponatremia. So think about it as dilutional. They're drinking a ton of water. Whereas patients with diabetes insipidus, they can't retain water, so they became hypernatremic. And the best initial test is a water deprivation test. Urine osmolality will increase with primary polydipsia, but it will remain low with diabetes insipidus. What is the recommended insulin regimen for patients with DKA? That's IV insulin, followed by sub-Q insulin, with an overlap period of 1 to 2 hours between the two administrations. Anti-thyroid drug therapy alone may be used to treat Graves' disease in mild disease, pregnant women or older patients with limited life expectancy. So how do the following laboratory results change in primary hyperparathyroidism? What happens to the PTH? It's going to be increased. And then because of that, remember, it results in calcium resorption, so calcium is going to be increased. And then PTH is also known as phosphate trashing hormone. So it's going to result in phosphate excretion, which will lead to a decreased amount of phosphate. What is the recommended IV fluid regimen for hydration in patients with diabetic ketoacidosis? 0.9% normal saline initially, and then after the glucose drops less than 200, you want to add dextrose 5%. So laboratory findings, etiologies, clinical features, and management of SIADH is coming up next. Sorry, the text is super small here. But so for etiologies, it's going to be CNS disturbances, medications, lung disease, ectopic ADH secretion, or pain and nausea. So stroke, hemorrhage, trauma, carbamazepine, SSRIs, NSAIDs, pneumonia, and small cell lung cancer can cause SIADH. Laboratory findings will show hyponatremia. Serum osm will be less than 275, so it's hypotonic. Urine osm is going to be greater than 100, and urine sodium is going to be greater than 40. Clinical features for mild and moderate hyponatremia will be nausea and forgetfulness. Severe hyponatremia would be seizures and coma. Remember, these patients are euvolemic, so they'll have moist mucous membranes, no edema, and no JVD. If it's a mild case, then you can give fluid restriction or salt tablets, but if it's a severe case of hyponatremia, you obviously want to give hypertonic saline. And then if all measures fail, you can consider adding demeclocycline, which is an ADH receptor antagonist, or you can give vasopressin antagonists such as the Vaptans. Acromegaly is an interesting disease process. So it results from increased soft tissue overgrowth throughout the body. So digits, hat size, all increase. And because of everything getting bigger, you can imagine that the patients are going to get bilateral carpal tunnel as well as OSA. They'll also have hyperhidrosis, coarse facial features, polyps, skin tags, bad odor, arthralgias, hypertension, and cardiomegaly. This is very high yield as well. Which medication do you give to diabetics who want to lose weight? You'll give GLP-1 receptor agonists such as exenatide. So any of the tides are going to be GLP-1 receptor agonists. And then next one is going to be painless thyroiditis, variant of chronic autoimmune thyroiditis. There's mild, brief hyperthyroid phase, small, tender, non-tender goiter, spontaneous recovery. So these painless thyroiditis is going to present with a positive TPO and a low radioiodine uptake. Positive TPO, low radioiodine uptake. In milk alkali syndrome, how do laboratory values change? Remember that PTH is going to be decreased and then calcium is going to be increased. So PTH decreased, calcium increased. What four medications should be administered to a patient with suspected thyroid storm? You want to give propranolol, like a beta blocker, PTU, and then you want to also give potassium iodide as well as prednisone or another glucocorticoid. So the 4 Ps. Propranolol, PTU, potassium iodide, and then prednisone. What is the likely diagnosis in a patient with pituitary mass in the following laboratory values? Prolactin is going to be 45, normal is less than 15, LH is low, TSH is low. This is a non-functional pituitary adenoma. Mild elevation in prolactin due to compression of the dopaminergic pathways, low TSH and LH due to compression of thyrotrophs and gonadotrophs, respectively. Subacute thyroiditis. So in subacute thyroiditis, there's going to be elevated ESR, CRP, and a low radioiodine uptake, and of course, sorry, I'm getting confused. Low radioiodine uptake. DPP-4 inhibitors, gliptin, inhibit metabolism of incretins, allowing increased insulin release and decreased glucagon release. Next one is excess thyroid hormone. Stimulates osteoclast activity, which produces hypercalcemia and hypercalciuria. If left untreated, then the patient can develop osteoporosis. So associate thyroid disease with osteoporosis. Which subtype of thyroid cancer typically invades blood vessels and metastasizes hematogenously? That would be follicular thyroid cancer. Patients that develop postoperative high fever, tachycardia, hypertension, and lid lag with no muscle rigidity. So key is no muscle rigidity. Serum creatinine kinase is elevated. That's thyroid storm. And remember, the 4 medications that you give in thyroid storm are propranolol, PTU, potassium iodide, and prednisone. What are the two types of diabetic retinopathy? That would be non-proliferative with hard exudates and proliferative. Proliferative has neovascularization and vitreous hemorrhage. What are the following laboratory results for osteofibrillation? So the way that they'll present this question is they'll have a person with bilateral pseudofractures, bilateral pseudofractures. And so the calcium is going to be decreased, or it can be normal. Phosphate is going to be decreased, and then alkaline phosphatase and PTH are both increased. So papillary carcinoma undergoes lymphatic spread. So there's going to be lymphadenopathy. Follicular carcinoma undergoes hematogenous spread, so there will be distant mets to the liver, bone, and lungs. These are all or some of the medications that you can give in terms of diabetes, like oral medications, and then their side effects. So metformin to begin with is weight neutral, and there's a low risk of hypoglycemia, but of course life-threatening side effect is going to be lactic acidosis. Do not give in patients who have kidney failure, because it increases the risk of lactic acidosis. Sulfonylureas, weight gain, and hypoglycemia are the main side effects, generally added in patients with metformin failure. Pioglitazone, if they're unable to tolerate metformin or sulfonylureas, side effect profile is pretty severe: weight gain, edema, CHF, bone fractures, bladder cancer, and low risk of hypoglycemia when used alone or with metformin. Can be used in renal insufficiency. Sitagliptin is an example of a DPP-4 inhibitor. There's low risk of hypoglycemia, it's weight neutral, and can be used in renal insufficiency. Last one here is GLP-1 receptor agonists, such as exenatide, which we talked about before. Exenatide. Possible second agent for metformin failure, especially if weight loss is desired, low hypoglycemic risk when used alone or with metformin. What type of drug is used to induce ovulation in patients with PCOS? That would be clomiphene citrate. Which is the first-line medication for irregular menstrual cycles in patients with PCOS? That would be weight loss and OCPs. What is the most important initial treatment in hyperosmolar hyperglycemic state? That's aggressive saline. Hyperglycemia causes osmotic diuresis. What is the formula for corrected sodium in the case of hyperglycemia? That's sodium plus 2 times, or sodium plus 2 milliequivalents for every 100 levels of glucose over 100. So if it's like the sodium is like 120 and the glucose is like 200, then you just add a 2 and then you get 122. Weight loss, rash with central clearing and eroded borders on right thigh, perioral diarrhea, anemia, and diabetes controlled with meds. This is most likely glucagonoma. Rash is necrolytic migratory erythema. Anemia is anemia of chronic disease due to the direct effect of glucagon on erythropoiesis. What is the most likely diagnosis in a female with irregular menses, hirsutism, male pattern baldness, elevated serum testosterone or an estrogen with no abdominal stria? That would be polycystic ovarian syndrome, so PCOS for short. What is the most likely diagnosis in a young patient with hypertension that develops severe weakness and muscle cramps after beginning a low thiazide diuretic? That would be primary hyperaldosteronism. Patients with primary hyperaldosteronism are prone to developing diuretic-induced hypokalemia. Other findings include metabolic alkalosis and mild hypernatremia. Malignant otitis externa is typically seen in patients with diabetes. Treatment is surgical debridement and anti-pseudomodals. And then treatment is going to, in terms of antibiotics, you want to give high-dose IV, high-dose ciprofloxacin. Secondary hyperaldosteronism is characterized by high renin and high plasma aldosterone concentration. High-dose dexamethasone reveals high ACTH, which is the next best step in management. That's chest x-ray / CT scan to check for lung cancer. Which of the following is the most likely in a middle-aged female with fatigue, GI symptoms, and skin hyperpigmentation? That's primary adrenal insufficiency. Skin hyperpigmentation and hyperkalemia help differentiate PAI from central adrenal insufficiency, such as Cushing's. Primary adrenal insufficiency is associated with increased levels of ADH in response to volume depletion and increased cortico-releasing corticotropin releasing hormone. It leads to dilutional hyponatremia. What does low ACTH indicate after a low dose dexamethasone test for Cushing's? ACTH independent Cushing's cortisol is iatrogenic and coming from the adrenals. What type of thyroid nodule, hyperfunctioning hot or hypofunctioning cold, is more likely to be cancerous? Remember, hypofunctioning or cold. So C and C, that's how you can remember cold for cancerous. Thyroid function is evaluated using thyroid scintigraphy, usually with I-123. Cold nodules should be evaluated with FNA. What is the most likely diagnosis in a middle-aged woman with hip, shoulder weakness, muscle atrophy, weight loss, and tachycardia? That would be hyperthyroidism, chronic hyperthyroid myopathy, proximal muscle weakness in the setting of hyperthyroidism. Symptoms improve with treatment of hyperthyroidism. What is the most likely diagnosis in a patient with weight loss, tachycardia, antithyroid peroxidase antibodies, and the physical exam findings below? Thyroid gland normal, non-tender, TSH low, free T4 high, radioactive iodine uptake less than 5%. That's painless, silent thyroiditis. Painless thyroiditis is often a self-limited hyperthyroid phase of Hashimoto thyroiditis, hence the anti-TPO antibody. So again, weight loss, tachycardia, anti-TPO, as well as normal thyroid, low TSH, free T4 is high, radioactive iodine uptake is less than 5. Which antithyroid drug, methimazole or PTU, is preferred in most patients? That would be methimazole. The exception is women during the first trimester of pregnancy because methimazole is a first trimester teratogen. PTU has a black box warning for severe liver injury. So remember, PTU, liver injury, PTU. And then methimazole is a first trimester teratogen. So you can think of the trimester as ME. Methimazole has ME. So that's how you can remember it's a first trimester teratogen. So you want to give PTU for the first trimester. Which tests help localize the involved gland of hyperparathyroidism? That would be ultrasound and nuclear imaging. So 99M, technetium, sestamibi scan. Those are the most commonly used. What do you do when a person has high-dose dexamethasone test, which shows low ACTH? The next step in management is going to be pituitary MRI to check for Cushing's disease. What pregnancy complication is associated with subclinical hypothyroidism? That would be miscarriage. Metabolic syndrome is associated with when 3 out of the 5 criteria are met. Abdominal obesity, fasting glucose greater than 100 to 110. Blood pressure greater than 130/80, triglycerides over 150, HDL less than 40 in men and 50 in women. When is radioactive iodine uptake low in evaluation of hyperthyroidism? That would be thyroiditis, iodine exposure, exogenous hormone. So you want to measure the serum thyroglobulin to differentiate between these ones. What is the most likely diagnosis in an African American patient that presents with dark blue urine that stains positive with Prussian blue after being treated for a urinary tract infection, probably getting an antibiotic that's exacerbating their G6PD deficiency? Positive stain indicates the presence of hemosiderin in the urine due to hemolysis. Hemolytic episodes are often precipitated by infection or medication, so there's increased oxidative stress. What is the effect of DKA on potassium and why? There's a total body potassium deficit. Acidemia causes potassium shift extracellular and lack of insulin to promote K plus uptake. Loss of intracellular K plus equals total body K plus deficit despite normal elevated serum K plus. Inability to lift the skin of the dorsum of the second toe is highly specific for lymphedema. Treatment is going to be weight loss, limb elevation, compression, and physiotherapy. What is the treatment of symptomatic or macroprolactinoma? Pharmacologic or dopamine agonists, carbergoline or bromocriptine of greater than 1 centimeter. Surgery if refractory or very large, greater than 3 centimeters. Which test should be used to screen for diabetes mellitus in patients with PCOS? That's oral glucose tolerance test. Which of the following is the most specific test for adrenal function? That's cosentropin test, AC stimulation test, otherwise known as. What are the results in primary, peripheral, and secondary central adrenal insufficiency? Primary cortisol remains low, ACTH is high, and central cortisol remains low and ACTH is low. Adrenal atrophy from chronically low ACTH not used to being stimulated. What is the next step in management for a diabetic patient taking metformin and nightly insulin glargine that presents with an elevated hemoglobin A1C despite normal fasting glucose levels? So you want to add a rapid-acting mealtime insulin. What is the most likely diagnosis in a patient with constipation, cold intolerance, low libido, and hypoglycemia with eosinophilia on a laboratory exam? That's hypopituitarism. Euthyroid 6 syndrome typically presents with the common pattern being usually TSH, T4, and free T3 are all low later on in the disease process, but initially the free T3 is the only one that's going to be low, and the reverse T3 is high. So high yield, because you can easily get asked like a question on that. Reverse T3 is high, free T3 is low. What are the indications for BRCA and mutation testing? Family history of ovarian cancer, any age, family history of breast cancer at an age of less than 50 and a first-degree relative. Rapidly progressive hirsutism with virilization. Is it PCOS or an androgen-secreting tumor? It's going to be an androgen-secreting tumor because it's rapidly progressive. Hypernatremia with the urine osmolality of less than 300 suggests diabetes insipidus. What antibodies are present in patients with Hashimoto thyroiditis? That would be antithyroglobulin or anti-TPO. Patients with a lump on the right side of the neck, TSH is measured and shown to be 0.03, which is low. What is the next best step? That's thyroid scintigraphy. So thyroid scintigraphy, next best step. What is the most likely diagnosis in a patient with a long history of Hashimoto thyroiditis that develops a rapidly enlarging firm goiter with dysphagia, hoarseness, and fever? That's going to be thyroid lymphoma. What is the most likely beneficial therapy for reducing the progression of diabetic nephropathy? That's going to be strict blood pressure control. What is the most likely diagnosis in a patient with low urine osmolality that improves to greater than 600 milliosmoles per kg after 2 to 3 hours of water deprivation? That's going to be primary polydipsia. MEN, so there's pituitary pancreas, and then parathyroid hyperplasia. 2 is going to be parathyroid hyperplasia, pheochromocytoma, medullary thyroid cancer. 2B is going to be pheochromocytoma, mucosal neuromas, marfanoid habitus, and medullary thyroid cancer. What is the most likely diagnosis in a patient that develops severe pallor, tachycardia, and hypertension without fever after induction of anesthesia? The patient has a history of frequent headaches and hypertension. That's pheochromocytoma. So don't get this confused with like thyroid toxicosis or anything like that, because remember, this is after the induction of anesthesia, so it's going to be pheochromocytoma. Which asymptomatic patients should be screened for diabetes? Less than 55 plus 1 risk factors such as obesity, first degree relative, African American, Hispanic, Native American, history of gestational diabetes or hypertension, or greater than 45. What is the most likely diagnosis in a patient with increasing polyuria, polydipsia with hypernatremia, high serum osmolality, and low urine osmolality? That would be diabetes insipidus. What is the most likely diagnosis in a patient with family history of kidney stones and stomach ulcers that presents with refractory peptic ulcer disease, hypercalcemia, and low serum phosphorus? That's MEN1. A patient with sensory motor polyneuropathy with symptoms of loss of proprioception, vibration, and sense, and large foot deformities has large nerve fibers that are damaged. How does oral estrogen change the required therapeutic dose of levothyroxine in patients with hypothyroidism? There's an increased dose required. How do patients present with insulinoma? What are their laboratory values? Serum insulin is going to be increased, as well as C-peptide level. And that's to differentiate between insulinoma and exogenous insulin use. Microalbuminuria is the early sign of diabetic nephropathy and correlates with overall risk factors of cardiovascular and renal complications. What is the most likely diagnosis in a patient with hypercalcemia, elevated PTH, and urine calcium? That's familial hypocalciuric hypercalcemia. Patients are typically asymptomatic due to mutation of calcium-sensing receptor in the kidneys and parathyroid gland. What thyroid abnormality, hyper or hypothyroidism, is associated with hyperlipidemia? That's hypothyroidism due to decreased LDL receptors, high cholesterol and or decreased LPL activity, high triglycerides. Patients may also develop hyponatremia and asymptomatic elevations in CK and AST, ALT. The initial step in the evaluation of Cushing syndrome is confirmed by hypercortisolism by one of the three following tests. First one is 24-hour urine-free cortisol. That's the best initial test, but it's very cumbersome to do. Other options are late-night salivary cortisol, and third one is overnight low-dose dexamethasone test. What is the first step in the treatment algorithm of patient with type 2 diabetes? Weight reduction, increased physical activity, nutrition therapy. If significantly elevated hemoglobin A1C or diabetic symptoms, start with metformin or insulin. What is the next step in management of a type 2 diabetic whose target A1C is not reached with metformin and lifestyle changes? That would be metformin plus an oral anti-diabetic such as sulfonylurea or DPP-4 inhibitor. What treatment option for Graves may be associated with worsening of an ophthalmopathy? We talked about this earlier. That's going to be radioiodine uptake. How do ionized calcium levels change in response to respiratory and metabolic alkalosis? It's going to result in decreased calcium ion because they're going to bind more to albumin in that case. Vitamin D deficiency will result in increased bone resorption, causing an elevated alkaline phosphatase. Hypocalcemia increases PTH, which increases bone resorption and phosphate excretion. Which initial tests should be performed in a patient with suspected adrenal insufficiency? Morning serum cortisol, plasma ACTH, and concentropin stimulation test. What is the most likely source of an androgen secreting tumor in a female with normal DHES and elevated testosterone? That's going to be ovaries, and that's more common. It can cause rapidly progressive hirsutism. Androstenedione, DHEA, and testosterone are all produced by both the ovaries and adrenals. DHEAS is predominantly produced by the adrenals, high yield. The indications for insulin therapy in diabetics is for a newly diagnosed patient with A1C greater than 8.5 or symptomatic diabetes, pregestational and gestational diabetes, as well as end-stage renal failure. What is the treatment for a patient with symptomatic primary hyperparathyroidism? That's parathyroidectomy. 1 unit of insulin lowers the blood glucose by 30 to 40 mg per deciliter. Diagnosis in a patient who has received multiple transfusions and develops paresthesias, carpal spasms, and hyperreflexia is hypocalcemia. What is the most likely diagnosis in a patient with hypercalcemia, elevated PTH, and high urine calcium? That would be primary hyperparathyroidism. What vitamin and mineral deficiency is associated with carcinoid syndrome? That's niacin or B3 deficiency. Which is the preferred first-line treatment for central diabetes insipidus? That's desmopressin. Intranasal is preferred over oral. What is the most likely diagnosis in a female that presents with proximal muscle weakness, such as hair combing and stair climbing, without pain, as well as hirsutism and hypertension? That would be glucocorticoid-induced myopathy. How do the following laboratory studies change in primary adrenal insufficiency? Cortisol will be decreased, ACTH is increased, aldosterone is decreased. How do the following laboratory values change in central adrenal insufficiency? Cortisol is decreased, ACTH is decreased, and aldosterone is normal, no change, secondary to glucocorticoid therapy. Anti-glutamic acid decarboxylase is specific for type 1 diabetes mellitus. The formula for corrected calcium in a patient with low albumin is serum calcium plus 0.8 times 4 minus the serum albumin. What type of insulin therapy is indicated in type 2 diabetics with persistently elevated A1C despite oral anti-diabetic regimen failed dual therapy? That would be basal-supported oral therapy, so long-acting insulin such as Glucagon or Lantus before bedtime combined with an oral anti-diabetic drug. The somagui, I don't know how to pronounce it, effect is caused by more early morning hyperglycemia that occurs in counter-regulatory secretion of hormones such as glucagon, cortisol, growth hormone in response to nocturnal hypoglycemia. What is the treatment? Reduce the evening dose of long-acting insulin. This is rare. What is the diagnosis in a patient who presents with flushing, watery diarrhea, hypokalemia, and achlorhydria? That's a VIPoma. So it typically involves the pancreatic tail. Abdominal imaging can localize the tumor. Remember that carcinoid can cause flushing, diarrhea, and bronchospasm, but it occurs in the small intestine, not the pancreas. What is the initial treatment for a patient with an asymptomatic microprolactinoma less than 10 millimeters? No treatment. A patient who wishes to get pregnant is found to have subclinical hypothyroidism. What is the next step in evaluation? Look for anti-TPO, treat with levothyroxine if it's positive. What antiretroviral drugs can have hyperglycemia due to insulin resistance? Protease inhibitors. Diabetic gastroparesis is a feature of autonomic neuropathy in diabetic patients, which can increase the risk of hypoglycemia due to delayed gastric emptying. What is the likely diagnosis in an asymptomatic patient with a slightly elevated TSH despite normal free T4 and T3 levels? That would be subclinical hypothyroidism. What is the diagnosis? And last point here, what is the diagnosis in a patient with elevated T4, low TSH, RAIU is less than 5%, and anti-TPO antibodies are present? That's painless thyroiditis.